Let's start our CNS cases, and I have, I think, one gynecological cases at the ready. Candidate one, this is you can request control, but please use the arrows to avoid any mistakes and avoid any answer shown.
Yes, sir. Yes,
Uh,
sir.
yeah, this is a 1 year old female patient presented with mm, now she is considered she has headache and
Okay.
some neurological symptoms.
Okay. So here, so I've requested control.
Yeah,
So you can scroll if you it is okay, like you can scroll, sir. Okay. So here
yeah,
I'm provided with T1 weighted MRI images, sagittal T1 weighted MRI images of this patient who has presented with some neurological complaints. Okay, so on these T1 weighted images, I'll just quickly go through the entire images. I can see that the vertebral bodies are appearing normal in height. Uh, I suspect that there is some expansion of the cord noted, which I would like to confirm on the T2 weighted images because I'm not able to see the CSF space. Yes, yes, I can see that on these images, I can see that there is some hypo in on these are the sagittal T2 weighted images in which I can see that there is some hypointensity seen serpentinous hypointensity seen overlying the cord in the region of cervical spine. Also checking the in the same images, I'm also checking the any there is no herniation of the cerebellar tonsils noted. So I'm also checking the cord for any altered signal intensity area. Yes, I'm not able to see. Okay. So to sum up, yes, and also the vertebral bodies are appearing normal in height. The intervertebral disc spaces are appearing normal.
yeah.
So I'm really
Mm.
suspicious of the intramedullary intramedullary altered signal intensity area noted just overlying the cord. I would like to see the other sequences as well for confirmation of my finding if any post-contrast images were done for this patient.
This is the post contrast. What do you think?
Okay, so so here I'm provided with the post contrast sagittal images, T1 weighted sagittal images of this patient. Uh, okay, so in this I can see that there is a diffuse enhancement of
Yes.
the TSF space noted along the cord. Also, in the I can see that there is a diffuse enhancement of the meninges noted, a leptomeningeal
Mhm.
enhancement noted in the visualized section of the cerebellum. So, yes, I can see that there is diffuse meningeal enhancement noted involving the cord, also of the brain. So I would like to mm, and yes, I can see that there are some serpiginous vessels, prominent vessels noted as well overlying the surface of the
Mhm.
cord.
So,
So, sir, I just want to know if any history of fever is there, if the patient is having any history of fever.
no.
So it could be, I'm just suspecting that could it be if the patient is having any so I would like to see the brain images if because I can see that there is enhancement of the leptomeninges as well. So if I want to know if any brain imaging any images of brain was done for this patient.
Yes, which sequence do you want for brain?
I think, sir, flare images, axial flare images would help me.
Before shifting to the brain, do you want to see anything in the spine else? Because it will be a different entity.
Uh, so I think GRE images if are
Let's
there.
see. Hey, doctor, you see a leptomeningeal enhancement of the dorso and the cervical spine. Do you want to see any other spine?
Um, yes, sir, yeah, so lumbosacral region, LS
Yes,
spine.
this is the lumbosacral. What do you think?
Yes, sir. In the region of lumbosacral spine, this is a T1 weighted. I think these are also the T1 weighted post contrast images in which I can see. Um, Again, sir, there is
Yes.
diffuse. Sir, there is diffuse. I think, sir. Mm, I'm just checking the. I'm checking the level of
No,
conus
don't
medial.
worry about it. Don't worry. What do you think?
Sir, I think, sir, this is a Zuckergus pattern. So I'm really suspicious for some intracranial neoplasm which can give rise to this appearance. Any leptomeningeal, diffuse leptomeningeal enhancements, or it could represent some drop metastasis from intracranial tumors like some a medulloblastoma or choroid plexus papilloma. So I would like to
Okay.
see intra.
What do you think? What do you want
So
next?
now I want I want DWI images, actual DWI images of the brain to look for any intraventricular neoplasms. I want to rule out any medulloblastoma
So
in this
you
patient.
want a brain MRI? Okay.
Yes, sir.
Sorry. Okay. Mute yourself, my colleagues, please. This is
Sorry,
the
sir.
brain MRI.
Yes, sir.
Everyone should mute himself except the candidate on the hot seat.
Yes, sir. So these are
See,
the
this is uh, suppose this one. Take this one. What do you think?
uh, okay, sir. So these are the sagittal T1 weighted I think sagittal T1 weighted MRI images of the brain. Uh, in which I can see that there is some hydrocephalus seen.
Okay,
Mm,
look the axial. What do you think?
okay. Uh, I'm just scrolling from I'm scrolling from craniocaudal direction. Um, so I would just like to have a look at okay. I can see,
What do you think? Look here. What is the name of this sequence, please?
sir, I think that this is a post contrast T1 weighted.
Yes. So,
These are post contrast T1 weighted images.
what do you
And
think?
I think so there is diffuse leptomeningeal enhancement noted.
Okay.
And
Okay.
I'm just checking for the cause of this diffuse leptomeningeal enhancement, checking for any intraventricular neoplasm, which could have caused diffuse leptomeningeal enhancement. The fourth ventricle appears to be normal. I'm not able to see any intraventricular neoplasm. Yes, I can see in the region of foramen of Monro, I could see an enhancing mass lesion in the region of foramen of Monro. Uh, uh,
Nothing. Nothing. So conclude, please. Conclude.
Okay, so in this patient who in this pediatric patient in which I'm provided with multiplanar images of MRI of brain and on spine,
On spine. Yeah.
I can see that there is diffuse leptomeningeal enhancement noted of the brain as well as the spine. And the patient is having no history of fever. So I'm just thinking in terms of some leptomeningeal metastasis. However, I'm not able to see any intracranial neoplasm. Uh, so
Could you have a look? You have a look at the brain stem and the surrounding structure, please. Look here. What do you think here?
mm, so um,
What do you think here also? Look at the cranial nerves, please. Could you detect anything?
Yes, so the cranial nerves are appearing very much thickened, sir, like bilateral. Yes, so there is thickening. I mean, there is enhancement noted along the bilateral trigeminal nerves as well, and the yeah,
Okay.
bilateral.
So in conclusion, you told me that you are concerning about leptomeningeal drop metastasis. Did you
Yes.
find the primary or not?
So I was not able to find the primary in
In this
this.
age group, what do you think the
So,
1 year old, the expected primary?
so I would have thought of medulloblastoma or so medulloblastoma is a possible choroid plexus papilloma, medulloblastomas. Uh,
What else?
so ATR, so ATRT, so that pterygoid rhabdoid tumors are a possibility.
Okay, okay,
Uh,
but see, intracranially now we didn't define the primary. Okay, thank you, Dr. Amiga. You did very well. Next
Thank you.
candidate will continue the rest of this case because it is very long case, but very interesting case. Candidate two,
Yes.
are you ready? Leave the
Yes,
mouse,
yes, sir,
Doctor.
I'm ready. Yes, sir.
Okay, okay,
So I think,
Doctor.
sir, in the break.
Oh, leave the mouse. Leave the mouse, please.
Okay, sir, I've left.
Please. Okay. Doctor, you was in line with us during the Dr. Omega discussion, correct?
Yes, sir. Yes, sir. I was there.
So finally, your colleague make a very great diagnosis of whole spine and intracranial leptomeningeal drop metastasis. What is and she can't find any intracranial or intraspinal primary in 1 year old age group. What do you think about the primary cause?
Neuroblastoma metastasis,
Excellent. What else?
lymphoma.
Okay. What else?
Yes, LCH.
But LCH will not cause this severe leptomeningeal
Uh,
enhancement.
no, there is like in uh,
Could
infants,
you
there is a condition. I
see?
don't remember the name of that condition.
Very good to discuss. Could you say, do you think LCH will present it without any vertebral affection in this age group?
Uh, no, sir,
Without,
I don't remember
eh,
the name of the spectrum of LCH. That condition comes in the spectrum of LCH. I don't remember the name of.
without any skull lesion. I will show something here to help you. Okay.
Yeah.
When we were revising the medical record
Yes,
of
yes.
this child, we found
Okay.
this X-ray. What do you think?
Okay. Okay. So this is basically periosteal reaction in the tibia, and this. Um what is the age of the patient, sir? Can I know?
1 year, 1 year.
1 year. So this goes in the favor of non-accidental injury. This periosteal reaction, there might be a fracture in the tibia. Uh,
Doctor, take care. This is the same patient of leptomeningeal enhancement.
okay. So,
Go on.
uh,
Mm,
sir, there is some lytic lesion uh, with the wide zone of
yes.
transition, some lysis in the noted
Okay.
in the mid part of the tibia with periosteal reaction. So
Okay.
this could be the primary, or this could be a part of the metastasis.
hmm So, what is your next step?
Um, uh, Sir, this could be basically. I would like to see the MRI of this limb if available.
Okay. This is MRI. What is the name of this sequence?
So this is T1 weighted image, and
Okay.
basically there
You
is
can.
yeah, there is altered signal in the marrow of the tibia with
Mhm,
periosteal reaction, lamellar periosteal reaction with some cortical erosion in the anterior part.
mhm.
Uh, Sir, I would like to see the fat suppressed images if available,
Okay. I think this one.
or any contrast enhanced images if available. Yes.
This one. Okay. What do you think?
Yeah, yeah. So I think there is a lesion in the center of the tibia shaft, and there is a sinus also arising from the tibial shaft and going into
Mhm,
the soft tissue with periosteal reaction. So this could
mhm.
be osteomyelitis as well. So this osteomyelitis might be leading to septic, like Hematogenous dissemination of the bacteria and leading to meningitis involving the spine
Mhm.
and the brain.
What else? But could
Okay, if
do you think, doctor, this large soft tissue component or
so
affection
this
more
yeah,
than see more than the
yeah.
bone? And most of the tumor is centered at the soft tissue. So what do you think? What is the first
Then it
differential
could be
diagnosis?
Ewing sarcoma.
Yes. So
Okay.
what is your next step? Look here. Sorry, this is not mine. Look here. This is the post contrast. This one. Hmm. What happened?
Okay, so I'd like to see this whether the soft tissue component is enhancing or not.
This is the post contrast. What do you think?
Yeah, I think the soft tissue component is also enhancing in the anterior part and the medial part of the limb.
So what's your final
Yeah.
diagnosis?
So looking at this whole picture, this could be Ewing sarcoma with metastasis to the leptomeninges of brain and spine.
What is the first your next step?
So my next step would be to refer the patient to the bone tumor clinic and go for the biopsy of this lesion.
Which type of biopsy?
So which type of biopsy? A core biopsy in consultation with the orthopedician can be done.
Yeah, but in bone sarcoma, there are a preferred type of biopsy generally.
Sir, I have no idea what type of biopsy
Surgical,
you're asking.
surgical,
Surgical biopsy.
surgical.
Okay.
Why?
Yeah.
Because if you put the needle here or here,
Yeah.
you will make a
Mm.
track. When you get the needle
Yeah.
out, there are some
Yeah.
dropping of the metastasis here.
Yeah. Yeah.
So
Yeah.
it may help with spreading of the sarcoma. Okay.
Yeah.
Doctor, what is the
Okay.
first line of treatment of the wing sarcoma?
Um, Ewing sarcoma, so it's a malignant tumor, aggressive lesion. Um,
Mm-hmm.
I think surgery is done in that case in Ewing sarcoma, followed by
No,
chemoradiotherapy.
no,
Okay.
no, no, no. What else?
So chemoradio?
Yes. Do you know
Yeah.
the percentage of success or
No
curative
idea. No idea, sir.
percentage?
Yeah. No
Because
idea, sir.
I was asked this question, by the way, in my Viva.
Like, what is the prognosis you're asking?
Yeah, 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 yeah.
Yeah.
Mm. Thank you,
No
doctor, so
idea, sir.
much.
Yeah.
Thank you so much. It is 50% respond to the treatment. What happened in this case? This case was a musculoskeletal case originally. Okay,
Okay.
but
Okay.
I make a brainstorm how to make it simulate the atypical case of Viva if we start from the end, from the spine. Look, if we start from the
Yeah.
spine, it will be very difficult, and that is happened in Viva. This
Sir,
is
what are these serpiginous structures on the medullary surface? Is this normal?
look here, leptomeningeal enhancement here,
Yeah.
almost. Maybe a
Okay.
combined vascularity, maybe. Okay.
Okay, but sir,
Anyway,
I thought that the
hmm,
subarachnoid space, the CSF is in the subarachnoid space.
which
Uh,
one?
so the black CSF around the cord outside this enhancement, I thought this is the CSF, and the CSF usually lies in the subarachnoid space. So this could be. Do you think this could be the pile enhancement that you're showing?
See, you talk about this?
Yeah. Yeah.
Yes, this is directly upon the cord, the
On the
pile.
medullary surface, cord surface,
Yeah,
yeah,
but
pyometer.
looks
Yeah.
like really some maybe some vascularity. Why not? Okay.
And sir, why were the cranial nerves thickened?
Yes, this is also
Okay. Okay.
okay. What happened here, my
Right.
colleague, and that is happening in Viva. I just inverted the case. I started from here, and this is legal. This is my right as an examiner. What
Yes.
happened?
Yes, sir.
Extensive leptomeningeal. You should look for all the images from up to down. The
Yeah,
key
for
of these
brain.
images,
Yes.
yeah, is the brain. If you look here, you will not get the whole idea. But here, the brain. Okay. Then
Right.
Then you must ask, and this is Dr. Omega forget, you must ask in any leptomeningeal drop metastasis for whole spine. Here, this is cervical and dorsal. So I helped here. Look here, this is extensive drop metastasis here. You should here below the conus see only CSF. All of these are soft tissue. Very important. Okay, very important. Why I am
Right.
insist in telling this, because most of us is not familiarly deal with the spine cases. Look, all of this is soft tissue. If you
Yeah.
forget or miss it, it will be fatal mistake. Okay,
Right.
and then what happened? What happened? I was waiting from candidate one to have a look in the cervical to the lung. At least have a look. Why? It may be ATP. Why not? Still, we don't know enough clinical data. So I'm waiting from her to ask me for axial, to ask me anything about the lung. If you find any pleural effusion here or any consolidation here, you should be in doubt about TB.
Tuberculosis. Yes.
Okay. Yeah.
Yes.
So she did very well when she asked me. I'm talking about candidate one about um, brain MRI. What happened here, my colleague? Take a very important home message. In flare and in post contrast, you should see the sulci as dark. This is the sulci as
Yeah.
dark. Even here, all of this is dark. But if you see something other than that, this is a pathology. Here you can mention it or call it leptomeningeal enhancement. And if you look deeply, looks like nodular. Oh, see, very obvious. Nodular subependymal enhancement. And this is against meningitis. Meningitis or any infection almost smooth. Okay? Almost smooth.
Right.
One of the most important to rule out or to confirm the leptomeningeal enhancement to look here at the surface of the brainstem. Okay? Look here. You will find some nodular enhancement. Look at even to the cranial nerve, very thick. Why? This is not in F2, in F1 or 2. Okay, so there must be another entity. It is a drop metastasis. What is our next step to search for the primary? Candidate one uh, talk too much about the intracranial differential diagnosis, despite there are nothing here. So next step, I should tell the examiner, doctor, I will search for the primary, either clinically, either by PET-CT. In this age group, I will do ultrasound for the abdomen to rule out neuroblastoma. Uh, I will search for all the possible age group related tumors. The surprising uh, point was here. What happened here? This is a sarcoma of the bone that metastasized to whole neural axis. And as usual, thickening periosteal reaction. Doctor, you forget I gave you this one and you didn't ask me for the lateral.
Orthogonal. Yes.
Yeah, see here,
Yes.
this is a large soft tissue. If you saw this one, you will not talk about osteomyelitis. Please
Yeah.
don't mention osteomyelitis in case like this. From
Right.
the beginning, it is a metastatic tumor, and we are searching for a primary. Okay, so
Right.
finally it was Ewing sarcoma. Ewing sarcoma must go. Uh, Special oncology bone sarcoma center for surgical biopsy, and chemotherapy is the first line of treatment. Asking about the prognosis, I was asked. Uh, that is what happened. Okay, 50% respond. Thank you, doctor, so much.
Thank you, sir. Thank you,
One
sir.
of the most surprising and confusing case. Candidate 3.
Hello, sir.
Hello.
So shall I ask for remote control?
1 second. Ask. This patient has headache. Go on.
Okay, I have been presented with axial CT images of a brain of a patient who is presented with a complaint of headache. These are, I'm going to the cranial part then.
Mm-hmm.
Okay, so I have been scrolling from top to bottom. And I can see there is a hypodense area noted in the right parieto-occipital region. It is involving the gyra and sulci. There is a loss of gray-white matter differentiation. Involving the part of the temporal lobe. This is likely in keeping with this can be a chronic infarct. However, I will confirm it on the MRI images.
Yes.
The ventricles appears dilated.
Mm-hmm.
There is evidence of a hypodense lesion.
Are you
In
sure
the
this is what is your differential here again?
sir, on the right side of the brain lesion.
Yeah, what is your differential?
So this could be an infarct or this could be a
This
encephalitis.
one? This one? Okay. And
Yes,
what
sir.
about the brain, the cerebellar lesion?
Okay. So there is a hypodense lesion in the left cerebral hemisphere, also involving the vermis.
What's
It's
your
quite
differential here?
heterogeneous. It could be a primary brain lesion or could be a
Mm-hmm.
metastasis.
Mm-hmm.
I would like to see further MRI images of the brain to confirm it. And it is also effacing the fourth ventricle, causing proximal hydrocephalus.
What is against infarction and what is shivering infarction?
Sorry, sir.
What is against in this lesion, cerebellar region? What signs are against infarction and what other signs are supporting infarction?
Sir, for infarction, I think it should involve the gray white matter junction and uh, also involve the cortical region. And it is quite ill defined. It is not following the trajectory of the posterior cerebral artery or any basilar artery.
So, so what is your first differential?
Sir, I would inquire the patient history. If patient is presented with an acute complaint with acute neurological deficit, then I would think of infarct. Otherwise, my primary differential for this could be a malignant lesion in the cerebellum. So I would further inquire with MRI of the brain to further confirm the finding.
With MRI.
So these are the axial T2 MRI images of the same patient, and I can say there is T2 hyperintense signals are seen within the left cerebellar hemisphere.
Yes.
It is causing sir. So you are scrolling.
Yeah, I'm scrolling.
Okay, so they are causing pressure effect over the ventricles, and it has a mild edema effect as well, and also compressing the medulla. I would like to see the post contrast images and DWI images of this.
This is supposed to contrast. What do you think?
On the post contrast, it has no significant enhancement. So this could be a cerebritis or could be a so I would like to see the DW images to see if there is a diffusion restriction. Oh, this is showing a diffusion restriction in guidiform pattern. So this could be an infarct of the left cerebral hemisphere. I would like to see the CT angio to see if there is any thrombosis within the basilar artery.
One secretary.
Posterior inferior cerebral artery, pica.
Okay. What's your other differential diagnosis?
Or sir, other could be a cerebritis or I think Lee-Hermite-Duclos syndrome, which is also give this type of picture. Or
But do you think the Hermit syndrome will show this great restriction?
or no, sir.
Yeah. So what's your final diagnosis?
So final is one is a acute infarct of the left cerebral hemisphere.
If
Let
it, if
me
it if it is clinically correlated with acute infarction, what is your next step?
then I will convey my finding to the referee physician, and this require a CT angio to locate the thrombosis in the artery, and also I will convey my finding to the neurology team urgently and the stroke team for further management. And
Okay, but
also the
your neurology colleague didn't want to do CT angio, and he wanted to do atiblase, which is a thrombolytic therapy. What do you think about its indication?
uh, okay, we will check the window period of this. If it is within the 3 to 4 hour, then
Okay,
the thrombolytic treatment can be started. Otherwise, not.
okay. After checking, we find that this is more than 6 hours. What is the proper next action
Um,
for a
then
patient with a stroke more than 4.5 hours, or he is 6 hours now? What do you think? What is the most suitable next step?
I think so. Then uh,
You refuse. You mentioned that before 4.5 hours, we should give thrombolytic therapy. I told you this is stroke after asking. We know that it is more than 6 hours. So no thrombolytic therapy with value. What is the other alternative treatment?
I think, sir, maybe catheter.
Yes, thrombectomy. Correct.
Yes, sir.
Thrombectomy. Okay. Your neurology colleague asking for the value or the significance of thrombectomy. Do you have any investigation in this case will can predict the value of uh, thrombectomy?
Sir, I'm not sure. Maybe perfusion images.
Yes. What is the parameter? What is the finding and its value?
Oh, sir, I don't know.
You know the penumbra, correct?
Yes, sir. Yes, sir.
Yeah. Talk about the penumbra. All of us, we don't know anything about the perfusion except the penumbra. So talk about it. Very easy, correct?
Yes, sir.
Go on. Give me any information about the penumbra.
Sir,
Say,
there is no.
say. I will tell you something. The question before I was asked during the coma really in the exam. I look at the eyes of the examiner. He told me, "What is the first line of treatment?" I told him surgery. He told me no. Then I told him immediately chemotherapy. So try to look at the eye of the examiner or be يعني, on the same line with him. What is in his mind? Okay. I'm trying to talk with you to pick up anything about the penumbra. Okay, go on.
Okay, sir.
What will happen in the penumbra? We don't have here perfusion.
Okay, sir. I think in a penumbra of there may be some part of perfusion, like it is not a ischemic part. Um, it is a like a
Yes,
savable part of the brain. It is not ischemic, not infarcted part
yes,
of the brain.
correct. Mismatching.
Yeah.
Mismatching. Yeah. So what happened, my colleague? In the perfusion, if you didn't find the mismatch, this is means all the infarcted brain tissue is totally dead tissue. So there will not be any use of any thrombectomy or thrombolytic therapy. That is the aim of perfusion. Okay. So perfusion, if you don't know anything about it, please know you must know something about penumbra and mismatching. What is the mismatching? This is the mismatching between perfusion rate and the volume. At least know these three sentences. Thank you so much, doctor. This case was confusing. Leave the mouse, please. Why this case was confusing, my colleague? Because of CT. It's CT really, uh, from the first look, looks like malignant or space occupying lesion. Really ill-defined, irregular. Even here, if you look here, the cortex is good, just subcortical or subfoliar. So it is يعني, more than 80% space occupying lesion. And second thing, the examiner make it more difficult when he hides the actual history. The actual history of this patient that I hide from our colleague, acute and sudden loss of consciousness. What happened? She gave me both possibility. This is the most important, both possibility. And she asked for MRI. What happened in the MRI? If you start with contrast, you will confuse yourself. I told you many times before, start with conventional. You didn't get much information about T1, get from T2. Look here. If you look, oh, there are cortic, foliar and subfoliar affection. Looks like wedge shape. Please give me the diffusion. The diffusion is restricted. And if she asks for SWI, she will find all of this hemorrhage or hemocentris. So it was an infarction of the territory of Baika. Okay, but it presented in the CT looks like space occupying lesion. All of us must read today about the treatment of the stroke, of the infarction, either by thrombolytic therapy, thrombectomy, or about the perfusion. Okay, very basic and very important information. Next candidate. This
Yes,
case
sir.
again here. Look here. This case was posterior circulation infarction. Okay, doctor,
Okay.
request control.
Sorry, can you scroll for me?
Yes. This is 25-year-old male patient presented with leg weakness.
Okay, I'm presenting with MRI, cervical and dorsal spine. Of 25 years old, presented with leg pain, sagittal T1. Vertebra appear normal alignment, normal bone marrow, normal height. At cervico-spinal junction, there is no brain herniation. There is no tonsillar herniation. Cord appear normal signal. I would like to check other sequence.
Which sequence do you want?
Stir
Yeah.
or T2.
This is T2. Okay.
This is T2, whole spine, sagittal image. I can see a long area of abnormal signal involving intramedullary abnormal signal involving thoracic and upper lumbar spine. I would like to check in axial T2.
Okay.
On axial T2, the spine appear not enlarged, and the signal seen within the central within the spine. No intra or extradural mass could be seen.
What do you think?
Okay.
Last sequence. Ask for last sequence, please.
Post contrast, T1 post contrast. On T1 sagittal post contrast, cord showed enhancement. The previously noted lesion showed enhancement, and there is enhancement dural, also dural, diffuse dural enhancement extend into the brain stem.
Yes. So, what is your next step?
I would like to check MRI brain.
For what? What is your concern? Your differential?
The diffuse enhancement could be due to infection or inflammatory. Okay, this is axial T2. I think there is draining tube.
Yes.
Yes, there is draining tube seen with tip at the third ventricle, no hydrocephalus. They are two hypointense lesion, one at within the ventricles. This could be air.
Yes. What else?
No focal lesion.
What else?
No intracranial abnormality. I would
Are you
like
sure?
to check.
Are you sure? Which sequence you want? Only one sequence
Flare.
No.
Flare.
Last sequence. Okay? Last sequence.
Okay. On flare, there is abnormal signal. There is a subdural collection within the basal cistern and right frontoparietal region.
Yes.
I couldn't appreciate the abnormality within the brain parenchyma. I would like to check axial T1 post contrast.
No. I told you only one sequence. What is your final diagnosis? Why? Because in the exam, even in case like this, no time to give you about 5 sequence in spine and the 3 or 5. I will give you 2 and 2 maximum. What is your differential diagnosis?
A differential diagnosis could be infection, meningitis, and spinal infection.
Okay.
This is the first.
Okay. Okay.
Given the abnormality, long abnormality within the cord, I'm thinking of demyelinating disease. However, I couldn't see abnormality within the abnormal signal within the brain.
Look here.
Mhm.
Do you think there are any helping findings for you?
Mm, uh, uh,
What happened here?
could I think there is abnormal signal anterior to the signal. This could be blood
Okay.
mixed signal
Okay.
anterior to medulla.
Okay.
This
Because
could
I'm
be
very kind examiner, I will give you this one. What do you think? Okay.
yeah,
What
this
do
is
you think?
post contrast.
Yes.
There is diffuse leptomeningeal enhancement.
What's your diagnosis?
Um, can I check orbits again?
Don't worry about it. What's your
Slowly.
final diagnosis?
Infective process.
Okay.
I would
Thank you,
like.
doctor. Yes, thank you so much. You did very well, but take care the answer was in this slice. Do
There
you
is
know why?
pleural effusion, yes.
What
Bilateral.
do you think?
Tuberculosis possible.
Yes, 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 yes. When you find, I just said in the case number one, first case of today, I said when you find a leptomeningeal enhancement of the spine, think about low metastasis versus tuberculosis or whatever. So try to have a look at the lung. Here was the tricky point here. Okay. By the way, typical case scenario of long cases exam. Typical. I give you a very, very long case full of details and just one clue, one in one slice. Like,
Sorry, can tuberculosis affect يعني I'm confused because there is intramedullary lesion. Can tuberculosis directly affect spine and giving the abnormal
see,
long
see. What happened here? Where is the main pathology? Intraparenchymal or meningeal?
meningeal? Yes, there
Okay.
is enhancement more.
Okay, this is first one. Second point, all of us know that granulomatous diseases, most of the granulomatous diseases can cause any parenchymal pathology. This is correct or not?
Yes.
Okay. But your eyes on the main pathology. This is mainly meningeal. Even when you go to the brain, mainly meningeal. Okay. What is the difference between this case and the first case? Look here, if you look, the enhancement is mainly smooth.
Yes, that
And
nodular.
second, I give you this slice in the flare especially. Basal meningeal affection.
Basal
Look here.
meningeal. Yes.
Very
Corridor,
characteristic. Look here. Very characteristic. Basal meninges. How could you find the basal meninges around the brainstem? Very easy. And the cranial nerves here. See, smooth signal abnormality, especially affecting. Look here. But here is more. The basal meninges. So it is more worse the granulomatous disease, especially TB. So what is the diagnosis of this case? This case was tuberculous meningoencephalitis with spinal cord involvement. Meningeal, no. What is encephalitis here? Because in diffusion, what is the fusion? I think this one. If you look here, you will find some infection in diffusion. Show you the splenium. Look, the splenium of corpus callosum. So there are encephalitis here also, here. Okay. So it was a tuberculous meningoencephalitis. Thank you, doctor, so much. Next
Thank you.
candidate. Next.
Yeah, good evening, sir.
Good evening. Doctor, this
Sir, I
is
have a question in the previous case.
yes.
The lesions you were showing just now about for the meningoencephalitis, can it be infarcts due to vasospasm, which is also a complication of the meningitis?
See, the scenario of case is running towards the tree, especially after I start showing the pleural effusion. This number one. Number two, I don't have any obvious clue to differentiate between is this true encephalitis or like ischemic insult for a lacunar infarction. But
Yeah.
we taking the case overall, which
Yeah, I mean we
more
can give the differential for infarct as well. If there is also a different restriction, then also it favors the acute infarcts.
so the examiner will kill us. Why? Case from the beginning starting as a leptomeningeal, and
Okay.
we are talking about either meningeal infection or meningeal drop metastasis. Then we saw,
Yes.
I'm trying to open the case, but I don't know, it's not opening. Then we saw pleural effusion. Then we saw smooth meningeal enhancement, mainly basal. So
Yeah.
it is running in towards the encephalitis. See, I know what is in your mind. My colleagues, in some granulomatous diseases, there are vasculitis, especially
Yes.
encephalitis, and Wagner diseases. This type of granulomatous diseases caused vasculitis should be followed by lacunar infarction or different size of
Yes.
infarction. That is our doctor asking about. Is this correct?
Yes, sir.
But I think this is not common in TB. It may be common
Common in TB.
in
Okay.
not
Okay.
common.
Okay.
Encephalitis is more common than
Mm.
infarction in TB. But in syphilis, or Wagner or Behçet, all of these three can cause vasculitis followed by different sizes of brain infarction. Okay?
Okay. Okay.
Especially which one of the three is more common to cause infarction of the last three granulomatous diseases? Which one?
Which one is most common to cause what?
Behçet, Behçet, or syphilis, or Wagner. Which one of them is more common or very common be associated with infarction?
I think Magnus should be because it's vasculitis.
No, Wagner is
Huh?
commonly associated with enhanced cystic or cavitary lesion, whatever in kidney,
Facets.
in lung. Behçet. Behçet is
Facets.
very
Yes.
aggressive thromboembolic disease. Very
Yeah.
aggressive. It causes vasculitis, followed by two different entity. One is thrombosis,
Mm.
another one is aneurysm. Two very different, but Behçet is a very bad and a very aggressive thromboembolic disease, especially in pulmonary arteries.
Yes.
Very one of the very aggressive uh, vasculitis related disease. Doctor, this
Mm.
patient, let's come again. Um, 15-year-old male patient presented with severe headache and seizures. 15 years old. Okay,
Okay.
you scroll
Uh.
or should I scroll?
Yes. I request. Request it. Yes, I have requested. Okay.
Go on.
Okay, so this is a axial MRI T1 weighted of 15-year-old male who's presented with severe headache. I'm just scrolling. It's a bit, actually there is a bit lag, so please bear with me. Uh, yeah. Yes, I can see there is a large area of altered signal intensity involving the left temporal lobe uh, with the slight mass effect, and it is appearing almost well defined with involvement of the apparently involvement of the cortex, and it is giving a heterogeneous and predominantly hypo-intense signal with surrounding uh, um, effacement of the ipsilateral trigone of the lateral ventricle, and is also causing slight mass effect with effacement of the uh, sylvian fissure as well as some basal cisterns. Okay, then um, can I have a look on the other images? I mean, other sequences like flare or any post-contrast image. Okay, this is a flare image of the same patient. On the flare image, the previously described lesion is predominantly giving a hyper intense signal with central areas of low signal intensity. Uh, Flare and T2. Can I look at the T2 just to see if there is any mismatch of the signal intensities?
Only
Uh,
one sequence allowed. Which sequence do you want?
I just want to compare the signal on T2 and flare.
This is the last one.
Last,
Mm,
okay.
last one.
Okay, for the 15-year old child and this cortical based tumor with mild mass effect and giving a low signal intensity areas within this lesion. I think my differential would include cortical based tumors like ganglioglioma or DNET tumor, and mm, in case of DNET, we see a bit a rim of high signal intensity, and that's the reason I was interested to look at the T2 and
Look
flare
here
images
again.
to see if
Have,
there is
have
any.
a look. Have a look here. Do you think this
Yeah.
is a tumor?
There are some areas of high signal intensity in it as well. Uh, mm, Linear areas of
What
high
else?
signal intensity.
Hmm. What else?
What else? If it depends on the presentation as well. If the patient is, if there is acute
Here,
presentation,
here,
this
here.
could represent an ischemic event as well. And with hemorrhagic component, I would like to look at the venous sinuses. It is in venous sinuses. If there is any
Which sequence you want?
uh, T2 to see any
Tito.
absence of flow void.
Okay, this is Tito.
Yeah. Okay, on this T2, uh, on the C2 image, I can see the superior sagittal sinus flow are maintained. I It's quite fast scrolling actually. Uh, I just want to focus on the yes, in this region, vein of labia and something transverse. I can't see the transverse sinus.
Don't worry about it. What else?
Oh, what else? If the sinuses are intact, uh, I mean, there's no thrombosis. The other could
Mhm.
be The cause could be an arterial. There is also significant edema of the ipsilateral cerebral hemisphere. I can see effacement of the sulci gyri on that. If you
So what's your differential?
uh,
Look here. What's your
yes.
differential?
Okay, these are MRV images of the same patient. I can see uh I can yeah, I can see the superior sagittal sinus and transverse sinuses both seem intact with the sigmoid as well. So uh, I guess
Mhm.
the mm so venous sinuses I mean no evidence of thrombosis.
So
Uh,
what's your differential?
others could be arterial causes,
What
arterial
kind?
ischemia. In that region, it could be territory of
So do you think real ischemia will be hemorrhagic like this? Look, like this. Mm, what do you think? I will help you. Finally, yeah, give me differential diagnosis before helping you.
this is SWI, right? And
Yeah,
I
yeah.
can see areas of blooming artifact as well. So this is is hemorrhage. But
Mm.
hemorrhage could be either a primary parenchymal hemorrhage, it could be hemorrhage in a lesion, pre-existing lesion.
So what's your
Uh,
differential diagnosis?
uh, I mean, this is hemorrhage, but I need to look. Yes, other possibility could be in a young child. Yes, avium. Yes, calcified avium could be another
Okay,
possibility. Vascular
look here,
malformation.
look here.
Uh,
What is the difference
Yeah.
between here and here? Did you
There are
find
some
any? Yeah,
less branches seen on the left side.
excellent, excellent.
Yeah.
The main dural sinus are patent, but
Yes.
the cortical veins
Cortical
here,
cortical veins are
this one
okay.
and this one not shown here, not
Mm,
shown.
uh,
Okay,
yes.
so it
Yes.
may be a cortical branch venous thrombosis or superficial venous thrombosis. Correct?
Yes.
Correct or not?
Yes. Yes.
Okay, why? Because there are
Yes, sir.
asymmetry here, paucity of veins that show in here. Correct? So, and we are dealing with
Yes.
hemorrhagic edema here, edema plus hemorrhage. We are in a big doubt about hemorrhagic infarct. So, it
Yes.
must not be a large dural sinus thrombosis. Why? Because because the large dural sinuses all are patent. It may be a cortical
Yes.
venous thrombosis that not showing here and just showing here by comparison. And was the correct answer. Isolated thrombosis of vein of Labbé. What is vein of Labbé? One of the cortical superficial branches. Whatever location, whatever.
It's a plus.
Okay. So, by the way, it
Mm.
was very confusing case, like today cases. What happened here, my colleague? This is a hemorrhagic lesion here. Put all possibilities. The most really confusing part, the age. The age is not a typical age for venous uh, infarction. But finally, it was the answer. What should we do? Hello? Can you
So
hear me?
then it needs an urgent immediate anticoagulation.
Yes. So my advice for all of
Yeah.
you,
A stroke.
both as much
Yeah.
as possible, logic differential diagnosis, especially when the case is borderline. What is mean by borderline? Everything is possible, like this case. Everything really is possible. We don't know really, is it tumor? Is it
So
hemorrhagic
can
infarction?
we give a can we give the differential of tumor on the initial images, like I say?
Yes, sure, because really it is very confusing. Even here, when you look here, most
And
of us
vascular
will not
malformation.
very difficult vascular formation here because in MRV you must see any draining veins, at least any draining veins.
Yeah. Okay.
But here the opposite, there are
Yes.
positive, there are decrease of number of veins here. Okay, thank you, doctor, so much. What is the answer again? Was
Thank you.
isolated thrombosis of one of the superficial veins called vein of Lappe. Next candidate, I think
Yes,
the
Assalamu alaikum.
Salam. Dr. Amiga, this is the last candidate. Doctor,
Yes,
you are
sir.
candidate 5 or 6?
Candidate 6 is she's the last candidate now.
Okay. Doctor, this is 50-year-old male patient presented with sudden headache and seizures.
Okay, so I am provided with the MRI axial images of an adult patient in which I can appreciate that there is a heterogeneous mixed intensity mass noted in the left frontal region causing mass effect on the frontal horn of left lateral ventricle. This mass has some cystic component in it and on the T1 weighted image. So I am thinking of these hyperintense component as a hemorrhage or a fat component, which I will confirm on the subsequent images.
Mhm.
I think, okay, there is no midline shift. A slight midline shift is noted. No hydrocephalus is seen.
Which
T2 weighted
sequence
image
do you want?
is needed for further evaluation.
Which sequence do you
T2
want?
weighted. T2 weighted.
T2?
So again, there is redemonstration of the lesion, which appears hyper intense, and some of them is hypo intense within it. It is a relatively well circumscribed lesion with cystic and solid component.
Mhm.
So again, I am thinking of some hemorrhagic or fat component lesion because it is hyperintense on T1, T2 weighted image. Next, I will want to see GRE images to rule out the hemorrhage, or stir image to rule out the fat component.
Okay.
As it
This
is an
is the
adult patient,
gradient.
I am also
This is the
okay.
gradient.
So there is a subtle same signal void which is seen on the T2 weighted image. So it is not a purely vascular lesion. If there is any fat suppression images, then I will want to see to rule out the fat component.
No fat separation. How can you
Fat
prove?
separation, I want to see T1 post contrast.
Post contrast? Let me see.
Yes. After seeing the T1 weighted image, there is no significant post-contrast enhancement seen within this lesion. Can I see side-by-side T1 pre and post-contrast image?
No, this is the
To
last chance for last sequence, and you must give me an answer. What do you think about it?
okay, again, there is multisectated cystic lesion with some hyperintensities and some flow void areas in the lesion in the frontal lobe with mass effect. There is no surrounding vasogenic edema. And I am thinking of, I am looking for the other images as well. No durovenous sinus thrombosis is appreciated. There is no.
This is MRS. What do you think?
This is MRS. I think this is a NA peak, an acetylcholine peak, which is.
Are you sure? Are you sure?
Is there are there some other images for MRS?
This is the only available
This
ones. What do you think?
this is not choline peak.
What does it mean?
That it is not abnormal neuronal abnormality within this lesion.
Yes. What
So
does this peak mean?
so it is not, if it is not a tumor and not showing any raised choline peak. Sir, I will correlate this peak with the
This is
other.
look 1 second.
This
This is one peak only of one item only. What does it mean? The answer is in this image. Where is the peak of choline? Where is the peak of N-acetyl aspartate?
Sir, I'm not sure at this time about the choline peaks, but I think choline peak is at 1.5 level,
Oh, okay.
and
Okay.
it is uh, I think it is also at the 1.5 ppm. I think so. So it could be a choline peak, but it is not raised. It is not as raised as should be in a tumor. I think so.
What is your final diagnosis?
So on this imaging feature of mixed echogenicity lesion, it could be in a 50-year adult male. So it could be a low-grade glioma with no
What else?
post-contrast enhancement. And
What
it could
else?
be, okay, it could be a vascular lesion.
What else?
Okay. No vascular lesion. So it is not look like an abscess. It is not like an infarct. It is not a looks like it is a basically tumor, but of low grade due to non post contrast enhancement, significant non post contrast enhancement.
Okay. Look, be online with me, please. 1 second.
Okay.
1 second. If I will show one image and you will give me the answer. Okay?
Okay.
Keep online.
Okay, sir. So,
1 second.
so could it be an ependymoma in an adult patient?
Look here. This is the normal MRS. What do you think?
So it is a lipid peak, which you have
Lipid.
shown to me.
First peak you see between one, it should be 1.2, like this. Anyway, then lipid is the first. Then at here in acetyl aspartate. Then the choline is the last one. Okay.
3.5.
Anyway,
Okay. Yes.
anyway, so our peak is lipid, correct?
Lipid peak. Yes.
Yeah. And we have
But
high T1, high T1, and this is
IT1
low
lipid
T.
containing lesion. Yes,
Yes.
it could be a dermoid.
And dermoid, very simple. And with
Yes.
calcification here. Okay? Calcification here. What is the
Calcification, yes.
what is the confusing word here? Oh, most of us need fat set to prove it. The examiner
Yes, sir.
used something atypical, non-familiar for us. He brings this
Okay.
one. Okay, he brings this one. And what else against the hemorrhage here? If you look here, look, the hemorrhage didn't have wall, fibrous wall. Look, this fibrous wall.
Yes.
Okay, look.
Okay.
And something which is has fibrous wall and high T1, high T2, and this doesn't cause too much edema or mass effect. Could you think if this hemorrhage, uh, the mass effect or the midline will be here, exactly not
Hmm.
shifted? There must be a great mass effect. There must be edema. Look here, nearly no edema.
Yes.
No edema.
No hesitation.
See?
No edema. Yes, sir.
No edema. So, um, as FRCR is at the consultant levels, the examiner will not maybe he will not give you a fat set, and he want from
Hmm.
you to know يعني, know to differentiate either this fat or not from other ancillary or non-major criteria. Like I will repeat it again. If this hemorrhage, you must see here marked edema, marked mass effect. Okay, you must see something. Okay, and in this age group, this the patient I think was 50. In this
Yes,
age
sir.
group, most of the hemorrhage are hypertensive, so you must see at the basal ganglion level, not here. Okay, and he
Okay, sir.
gave you the MRS. This is the lipid lactate about 1. Look, if you look here, nearly at the 1. Okay, next to
Okay,
it
sir. Thank you.
in acetyl aspartate. Next after about at the 3 or 3.3, like something like this, is the choline. Thank you so much. Thank you for all of you, my colleague. It was very great session. Dr. Amiga, do we have any candidate?
So we are done with the 6 candidates. Thank you. Thank you so much, sir.
Okay. I think I have one nice case. If any candidate want to join for 5 minutes,
I think
Yes, sir.
you
I
have.
want to.
so we have a
Okay.
backup candidate, so we can go for the backup candidate. So we have
Yes.
Dr. Lean. Dr. Lean is there if she's available, or we can go for Dr. Munir Nigam. Dr. Lean? Dr. Munir Nigam, you want to go for?
There are one candidate who asked.
Dr. Nagam, you want to go for?
Yes, sure.
Okay. Anyway, this 13-year-old female
Dr.
patient
Nagam, I think
presented.
Yes,
Munir has
yes,
responded. Munir has responded,
yes.
Dr. Nagam.
Okay, give
Okay.
him priority.
Yeah. Dr. Munir, you can
Dr.
go for it.
Munir, welcome.
Yes,
This is
yes.
13-year-old 13-year-old female patient presented with primary amenorrhea. Go on.
Okay, بص. Can I ask for remote control or
Sure.
request those? Can you hear me, Dr. Rami?
Yeah, go on. I listen to you
Oh,
well.
okay. I
Dr.
presented
Munir,
with
can I scroll for you? Because I'm fair about shifting of the to the answer. I will scroll one by one. Okay.
no problem.
Okay. What happened here?
This
I think
I
last
presented
time some Arabic candidate shifted to the answer immediately.
no problem. I
Okay, go
presented
on.
with sagittal T1 MRI of the pelvis of a male patient. I couldn't see
Presented with
well
amenorrhea. Yes.
okay. I can see the vagina, but I couldn't see well the uterine cavity.
Uterine cavity or uterine proper?
The uterus itself, I couldn't see. I can
Uterus
see
itself.
only
Yeah.
I can see the vagina.
Which sequence? Okay, which sequence do you want?
I need axial T2 sequence.
Okay.
I couldn't see also the uterus in this sequence, and also I couldn't see the ovaries.
Okay.
I will go down to see any testicular organ or anything like this.
Okay. Did you find anything?
No, I can I scroll for myself, please? I couldn't concentrate about yeah.
Okay, one by one. One by one.
Okay.
One by one.
I will not go for any further data, but I can scroll.
See. Asking for the proper sequence will give you the answer. Which sequence do you want? Which sequence do you want to rule out something or to prove the presence of something? Something important in this case.
That's that sequence.
Okay. That's it. Okay, go on.
Okay. Wait a boss, I can see. Really, I couldn't appreciate any.
Which sequence you are 100% sure about the presence or absence of testes? In which sequence?
Absence of this. I don't know, but maybe post contrast
No. Look here.
diffusion. Okay.
What is the name of this sequence?
Diffusion with damage.
Did you find any testicular tissue or not?
I'm searching for any. No,
What's your final diagnosis?
this. I think it's the case of ambiguous genitalia.
Okay, do you know any syndrome? Because many syndromes may present
Oh, maybe Klinefelter syndrome.
what else?
Uh, I
If
don't
I
know.
told you
This.
testis is restricted in diffusion, and the diffusion is the best sequence to detect intra-abdominal testis. What is this?
Maybe this one tested because I saw so many restricted areas, so I am
Yeah. But see,
confused.
this is the only different one. All of them are lymph nodes, except this very restricted and larger. Okay?
Is this maybe one test yes on the right side?
Yes, and I have a doubt about this one. Inguinal, left inguinal. But this is
Yes,
lymph
this one
node.
also lymph
What
node.
is your diagnosis? What is the name of this syndrome, which we didn't see the uterus and cervix and the small part of
I,
vagina maybe here?
I think
Both ovaries are not seen.
double XY syndrome.
See, this is androgen insensitivity syndrome.
Oh.
Androgen insensitivity syndrome. This is XY karyotyping. What happened in this syndrome? uh, external genitalia of a female with testes. So there are no uterus, there are no ovaries. The organs here are not sensitive, not responding to the testosterone. So there are testes which produce the testosterone, but the external, this is the testis, excrete testosterone. But the external genitalia tissue does not respond to this testosterone. So the name is androgen insensitivity syndrome. The other differential diagnosis, in my opinion, is Mayer-Rokitansky-Koster syndrome. But Mayer-Koster syndrome is a female, true female XX. You just see absence of uterus, absence of ovaries without testes, with normal external female genitalia. So
By the
the
way,
difference
Abbas,
between
this case came in long cases in the last exam. Our colleague and describes this syndrome. Like, but really,
we
I
are
don't
trying to
understand.
collect as much as possible a typical case. What is the difference between both of them? Both of them are typically this one and this one. But having androgen insensitivity, you must find any evidence of testicular tissue. Okay? Because this is XY person. But as Mayer-Koster syndrome is an XX, you will not find testes. The differential diagnosis of Mayer-Koster is Turner, and but it is XO. Thank you, my colleagues, so much. Thanks for our coordinator. Hopefully, we will meet next week. Thank you, doctor. Goodbye.
Thank you so much.
Bye.